Welcome, everybody, to the second part of our glaucoma innovation series. We're really excited to have a highly requested speaker, Dr. Ibach, with us today. My name is Dr. Stephanie Wu, and I am the founder of Wu University, and I am your host for this evening. And it's now my pleasure to introduce our speaker for tonight. A lot of you have already heard from Dr. Ibach because he has spoken for Wu U on a variety of occasions. Everyone loves hearing from him. I'm really excited to hear from him tonight. He is a residency trained optometrist at the Vance Thompson Vision in Sioux Falls, South Dakota. Dr. Ibach attended the Pacific University College of Optometry, where he graduated summa cum laude. Mitch completed his residency training at the Minnesota Eye Consultants and concentrated on cornea, refractive surgery, external disease, and glaucoma. And then in September of 2014, he joined Vance Thompson Vision to focus on advanced anterior segment surgery and pathology. Mitch is a fellow of the American Academy of Optometry, an intrepid Eye Society member, a member within the American Optometric Association, the Optometric Glaucoma Society, and the South Dakota Optometric Society. He serves as the Associate Residency Director at Vance Thompson Vision, and he's also an adjunct clinical professor for the Illinois College of Optometry and the Pikesville College of Optometry. And Dr. Ibach is very well-versed not only in glaucoma, but he also has lectured for us on anterior segment things as well. So it's really rare to have a doctor that specializes from the front to the back of the eye. So we're really lucky to be hearing from him tonight. Thanks so much, Dr. Ibach, for being here.
Thanks so much, Stephanie. I really appreciate the warm welcome, and it's great to be back. Good evening, everyone. Using cases as our foundation, we're going to run the glaucoma gauntlet for the next 50 minutes. We're going to discuss what matters in glaucoma. We'll talk about diagnostic devices. How do we make the diagnosis in glaucoma? And then we'll look at treatment options, which will include both pharmaceutical options as well as some surgical approaches that we can take for glaucoma patients. We will try to use polling through Zoom tonight. Please participate. It helps engagement, hopefully helps drive some discussion on maybe some points that we want to spend a little bit more time on as well. And hopefully at the end of our 50 minutes, right at the time for questions, you're not feeling as labored as I would be if I did a Tough Mudder or someone who's doing an Ironman like this gentleman here. Here are my financial disclosures. All relevant relationships have been mitigated. I'm lucky to have some great partnerships in industry. And so before we start with our first case, let's discuss what matters in glaucoma. Just like fitting this slide together was a puzzle, the diagnosis for glaucoma is like this big puzzle. I think of different puzzle pieces. We have to add up our patient's risk and put the puzzle together. For me, 8 main things matter in the diagnosis of glaucoma. And this translates into trying to define the risk of progression for our patients as well. But unlike diagnosing glaucoma, treatment in glaucoma is unilateral. It's just one thing. We try to lower the intraocular pressure. There's some other theories, some tests that are being done, but currently we're just lowering IOP. And so let's jump into our first case. This is patient LM, 65-year-old female. Chief complaint was I was told I'm at risk for glaucoma. You can see the visual acuity is good. Patient's currently not taking topical medications for the eye. Intraocular pressure is on the high side of normal. This is definitely an ocular hypertension patient. We're unsure of her Tmax. It's the first time we've seen her. We did get some referring notes from her referring doc. Corneal hysteresis is 10.5 in both eyes. Pachymetry is thick. Optic nerve head evaluation of 0.5 and 0.6, and gonioscopy is open to ciliary body in both eyes. As we jump into our advanced diagnostic tests for glaucoma, here's the optic nerve head OCT. Right eye is shown on your left eye shown on your right. In both eyes, if I look at the Tisnet curve, I look at that third kind of picture on the left side, we're in the green. The reliability on the B scan right above that looks pretty good to me. And so overall looks pretty normal. We lost a little bit of that section supratemporal on the patient's right eye. Here's the visual field. So now matching structure and function, left eye shown on your left, right eye shown on your right. And we can see here, this is reliable test and no definite glaucomatous visual field loss is what I said for this patient. And so we have a 65-year-old patient, pressure is 27, thick pachymetry. We just looked at the diagnostics that we had available. And so what would you diagnose for this patient? A, ocular hypertension, B, preparametric glaucoma, C, mild POEG, D, low-risk glaucoma suspect. Let's look at our first poll here. And so let's see our results. So just over 50% said that this is a patient with ocular hypertension. And then the other three answers were pretty split between preparametric glaucoma, mild POEG, and low-risk glaucoma suspect. And we may have some overlap in those answers. And now let's follow up with that. For the management of this patient, I would A, start a prostaglandin analog like travoprost once a day. B, I'm referring or doing selective laser trabeculoplasty, depending on where you practice and what your scope of practice is like. Recommend monitoring with an IOP check in 3 months. Recommend monitoring with OCT IOP visual field in 6 months. 20% said they're starting a prostaglandin analog. The majority are going to monitor, with the most common answer being visual field, OCT, and IOP in 6 months. And that's exactly what we did in our practice here for this patient. And so I said, this is a patient with ocular hypertension, and I'd bring this patient back in 6 or maybe more commonly 12 months in my practice, and I would repeat testing. But why? How did we get to that decision that we just made? Well, I think this patient fits very well into the ocular hypertension treatment study, or the OATS study. This was a huge study. Over 1,600 patients were studied. These patients all had high eye pressure, and the primary goal was to look at the risk of going from high eye pressure to glaucoma. In one eye, patients had an eye pressure greater than 24, less than 32. In the contralateral eye, the pressure was between 21 and 32. The primary endpoint was at 5 years, and they had 2 groups. They had patients who were untreated, the control group, and then they had patients who were treated. And at 5 years, in the patients who were in the control group, 9.5% of patients, we'll just round that up to 10% of patients, progressed from high eye pressure to glaucoma. In the treatment group, 4.4% of patients progressed in 5 years from high eye pressure to glaucoma. And so I think there's 2 ways that you can think about the data here from the OATS study. In a patient with high eye pressure at 5 years, 90% of them aren't getting glaucoma, whether you treat it or you don't. You could also say, treating the eye pressure, trying to lower eye pressure in an ocular hypertension patient, reduced the risk of going from high eye pressure to glaucoma by 50% in the OATS study. The OATS study also told us that 5 things really matter in the risk of going from high eye pressure to glaucoma. And we have some newer tests now, so that may have been aligned in the OATS, but this was before some of their time. But in the OATS study, 5 things matter. Age, increasing age is a risk factor for conversion. IOP, higher baseline IOP, stronger correlation with progression to glaucoma. Central corneal thickness, thin corneal pachymetry being a risk factor. Vertical cup to disc ratio, or cupping. And then finally, visual field, specifically pattern standard deviation. Hot off the press, though, is the 20-year follow-up from the OATS study. And so these same patients, high eye pressure, they looked at the risk of going from high eye pressure to glaucoma. And shown on the left, 45% of patients, that's combined both cohorts, treated and untreated, went from high eye pressure to glaucoma. If you look at the line graph here, on your x-axis is years from baseline. On the y-axis is the incidence of POEG. And 49% of the control group at 20 years went from high eye pressure to glaucoma, 50%, and 42% in the treatment group still went from high eye pressure to glaucoma. Some other take-homes of African-American patients showed a significantly higher conversion rate. And then when you pool the data for both treated and untreated patients at 20 years, the cumulative rate of visual field loss was 25%. And so 1 out of 4 patients had visual field change. And so my next question is, do I need an OCT in 2022 to do a good job of managing glaucoma? Optical coherence tomography is a non-invasive cross-section imaging tool that we can use for multiple parts of the eye, but specifically for the optic nerve. We know so much more about glaucoma pathophysiology because of our advanced ability to both identify and monitor structural changes on the optic nerve over time. We can now follow this. In glaucoma, we use the OCT to look at the peripapillary retinal nerve fiber layer, or the RNFL, the macular nerve fiber layer, ganglion cell layer with interplexiform layer, and then the ganglion cell complex. And remember, as much as 50% of the retinal ganglion cells, those cells we're really keying in on in glaucoma, are located in the macular region. We have thicker retinal ganglion cells there as well. And so it may be easier to image these, and these central retinal ganglion cells are correlating with more central visual field loss. And so this is a big focus right now in diagnosing glaucoma, is this change to more of the temporal retinal nerve fiber layer or ganglion cell analysis. This is a meta-analysis of 150 studies reviewing OCT's ability to diagnose glaucoma. So do I need an OCT? In this study, they looked at the area under the curve. Think of that as the accuracy of being able to say, yes, this is glaucoma, or no, it's not. The accuracy in diagnosing. 0.9 or above would be considered an A. That's a really good area under the curve. 0.8 to 0.9 would be a B. That's overall very good as well. And in 16,000 glaucomatous eyes across brands, all devices performed similarly. And then of the RNFL area, if you look at average RNFL, almost a 0.9 area under the curve. And so very good accuracy for diagnosing glaucoma, followed by superior and inferior retinal nerve fiber layer. These were the most strongly correlated or accurate diagnostics for diagnosing glaucoma. In general, macular thickness values were similar in accuracy to RNFL. And so OCT is very precise. It's very accurate in diagnosing and monitoring glaucoma over time. There's lots of ways to look at the printout. Here's how I kind of approach this. This is Heidelberg's printout here, but they all kind of have some similar traits to them. First of all, I'm going to pay attention to the Tisnet curve. That's the third image on the left from the top. It's kind of some wavy lines, almost an M shape, red, yellow, and green. Be careful just looking at color though. Green is good. Yellow means slow down, red means stop. We really want to make sure that that adds up and it correlates to what we're seeing when we look at the structure with a 90 diopter or superfield lens. Pay attention to the actual numbers. I like to look at the segmentation plot numbers as well. This is very precise, but don't get caught only looking at that. Compare the numbers right eye to left. Remember, glaucoma is asymmetric, and so we want to look for change where maybe one eye has some thinning and one eye doesn't. And then finally, beware of the artifact. Right above the Tisnet curve, the second image from the top on the left is your B scan. And we really want to make sure that we're catching the interlimiting membrane and the retinal nerve fiber layer. Are we measuring correctly what we're hoping to then grade and analyze? Make sure that we're getting good accuracy on our scan. And then finally, the picture on the top right, this is your macular asymmetry map. This is looking at more of those retinal ganglion cells. And you can see on the lower part of this scan, we have this dropout here, almost this wedge defect. And so paying attention to that as well. I also think we now know that corneal hysteresis matters in glaucoma. Corneal hysteresis is a measurement of the corneal biomechanics. I think of it as the shock absorbing properties of the cornea. How well can this cornea and resulting eye absorb shock or changes in pressure? The average corneal hysteresis in the American population is 10.5. Clinically, below 9.5 for corneal hysteresis is a risk factor for me. This is a patient that doesn't absorb shock well. The theory is poor shock absorbers on the cornea, poor shock absorbers on the sclera, which translates to the back of the eye, the optic nerve, and the level of the lamina cabrosa. This is an eye that can't absorb shock or changes in pressure well. This is an eye that's going to cup when we have changes in pressure. Conversely, high corneal hysteresis, good shock absorbing properties on the cornea, sclera, optic nerve, and the lamina cabrosa. This is an eye that is resistant to pressure changes or doesn't bow backwards. Research has shown that low corneal hysteresis has been consistently and independently strongly associated with prediction of glaucoma, as well as looking at progression in glaucoma. And so first, let's look at the progression, let's look at the risk of going from glaucoma suspect or high eye pressure to glaucoma. Who's going to get glaucoma? This is a study by Susanna et al. It's published in Ophthalmology. 287 glaucoma suspect eyes or patients with ocular hypertension. They watched these patients on average for 4 years with visual field follow-up. And what they found is about 20%, 54 of the 287 eyes went on to developing glaucomatous visual field loss. In the patients, the 19% that went on to get visual field loss, the mean corneal hysteresis was 9.5 millimeters of mercury. Compared to the group that did not have visual field loss, it was 10.2. The study concluded that every 1 millimeter of mercury lower the baseline corneal hysteresis was equated to a 21% increased risk in developing glaucoma. And so corneal hysteresis is a helpful tool in this ocular hypertension or glaucoma suspect patient to say who's going to be at the highest risk of conversion. And so let's check back in on patient LM. We saw this patient back 6 to 9 months later. We're seeing them again now 15 months after first presentation. She reports no changes in vision. She's best corrected to 20/20 in both eyes still. IOP is 23 in both eyes. Remember, our Tmax was higher. Visual field and OCT we'll look at on the next slide. Optic nerve head evaluation, maybe a little bit more vertical cup to disc ratio on the left eye and still not taking any medications. And so here's what we see on sequential or serial OCT follow-up for this patient. We're in the green. So we should be good at baseline 6 months and 15 months, but slow down. We can have progressive OCT or retinal nerve fiber layer change and still be in the green. This is why we have to be careful with just using stoplight grading. If you look closely in these blue rectangular boxes here, in the superior and inferior retinal nerve fiber layer, we're having loss. It's a patient with an IOP of 25, PACI of 580, and still a clean visual field. So for this same patient now sitting in front of you, what would you suggest? A, starting a prostaglandin analog like latanoprost, B, SLT, C, monitoring with an IOP check in 3 months, or D, I would start a beta blocker like timolol twice a day. And so almost 70% are going to start a prostaglandin analog once a day. Second most common answer was SLT, and we had still about 15% saying they're going to monitor this patient and check the IOP in 3 months. And so that begs the question, what change matters on OCT? I think this is a really helpful study, and this study proposes that change within 1 year, the average retinal nerve fiber layer, if we're having about 4 or more microns of loss, circled in blue to the right, and the average RNFL, this is significant for change. Superior or inferior retinal nerve fiber layer loss of 7 or more microns within the same year between 2 tests is considered significant change. And then macular ganglion cell interplexiform layer loss of 4 or more microns in that same year would be considered significant change, according to this study below, published in IOVS. And so I think that's really helpful to say, what change matters for my patients? I'm still in the red or I'm still in the green, but I see the Tisnet plot going down. I think this is helpful as we make treatment decisions. It's also important to remember that our retinal nerve fiber layer decreases as we age. The normal change is about a 0.5 micron per year when we're talking about aging. And so I wouldn't expect to see the same RNFL thickness in my patient at age 50 as I do when they're now 55. We expect to see normal loss of a 0.5 micron per year. And so for this patient, we decided to start treatment with a topical prostaglandin analog once a day in both eyes. Drops are still the most common first-line treatment for primary open-angle glaucoma in the US. I think this table does a really nice job of giving us an overview of our most commonly prescribed and dispensed topical glaucoma medications in the US today. There's some others. This is not an all comprehensive list here, but these are the most common ones that are getting written in the US today. For glaucoma drops, we really have 3 main targets for mechanism of action. We can try to decrease aqueous production. We can try to increase trabecular meshwork outflow, or we can try to increase uveoscleral outflow. And so I always make the analogy in glaucoma with my patients. Glaucoma is like a sink. There's a faucet or pump that makes fluid and then a drain that drains it out. In glaucoma drops, we can try to turn down the faucet, or we can try to get the drainage mechanisms to work better. And we'll talk more about that. To better understand glaucoma treatment, though, I think it's really helpful to go back to anatomy, physiology, and think about the production and drainage of aqueous inside of the eye. I think this helps make the mechanism of action make more sense. And so aqueous is made in the posterior segment at the level of the ciliary body and ciliary body epithelium. Aqueous has to travel around the lens through the pupil, and then it enters into one of two anatomical drainage pathways. First, we have the conventional outflow pathway. This makes up 50 to 90% of aqueous outflow through the trabecular meshwork into Schlemm's canal, picked up by the aqueous collector channels, and then branches off into the aqueous veins and episcleral veins. Trabecular meshwork, or conventional outflow, this is where our topical medications, notarsidil plus latanoprost, pilocarpine, latanoprostine bunad, have primary targets to lower the eye pressure. This is one of the main mechanisms. Bimatoprost or Lumigan has a study that maybe helped increase trabecular meshwork outflow, but that hasn't been shown multiple times. And so these are the four that we'll focus on for TM outflow. For the aqueous that doesn't enter the trabecular meshwork pathway, then we have the uveoscleral pathway. This is a secondary pathway. Fluid goes in between the iris root and the ciliary body. And this is where prostaglandin analogs work. 10 to 50% of aqueous outflow goes through this uveoscleral pathway. And so latanoprost, travoprost, bimatoprost, tafluprost, and latanoprost BAK free. And so that's the drainage, or we can try to turn down the ciliary body, have it make less aqueous. We do this with our aqueous suppressants. We see the bottom three being our combos: dorzolamide, timolol, brimonidine, timolol, and dorzolamide, brimonidine. And so why are prostaglandin analogs first-line treatment, most commonly dispensed drop for glaucoma as first-line in the US? Well, first, it's the most efficacious drop class that we have. 25 to 33% reduction in IOP is what we expect to get in the literature with a prostaglandin analog. These are once daily dosed. There's lots of studies that have now said patients with topical glaucoma drops, unfortunately, compliance isn't good across the board, but it definitely gets worse with increasing the amount of doses that a patient has to take or increasing the amount of bottles that a patient has to use for glaucoma medications. With prostaglandin analogs, we have minimal systemic side effects. We know of kind of the big three for topical or ocular adverse events with PGAs. We have periorbital fat loss or kind of hollowing out. We can have eyelash growth, iris pigmentation changes as well. And then a big key for me with prostaglandin analogs is uveoscleral outflow slows at night. There's studies that have been done by Dr. Arthur Sitt, as well as others who have shown that when we're lying down, we're sleeping, uveoscleral outflow slows, which may be the main culprit for having that nocturnal IOP spike. And so if we can try to blunt this or have uveoscleral maybe uptick just a little bit, we can try to block that nocturnal IOP spike. This study on the right is published in Lancet. This is the United Kingdom glaucoma treatment study. 516 newly diagnosed primary open-angle glaucoma patients previously naive to treatment were randomized to either latanoprost once a day or placebo, no treatment. On the right, what you're looking at on this line graph is the hazard ratio for visual field progression. In the patients who were untreated, their hazard ratio was 1. In patients who were on latanoprost once a day, hazard ratio of 0.44. Another way to conclude this would be decreasing visual field progression by over 50% by having patients on a topical PGA once a day compared to control. Hopefully that makes sense. So we established that in the US, prostaglandin analogs, most common first-line drop out the door. What prostaglandin should I use? In the US, latanoprost generic by far has the largest market share, but should it be this way? Should we be considering some of these other newer molecules that maybe can be more effective? At least that's what this study would show here. This is a study that looked at patients taking monotherapy in primary open-angle glaucoma. They were previously naive to treatment, and they were started on either latanoprost once a day or bimatoprost, which is commercially Lumigan, once a day. 60 patients, baseline IOP on average, 25 to 26 millimeters of mercury at the morning IOP check. Primary endpoint was 3 months after starting the medication. Latanoprost lowered IOP 6.5 millimeters of mercury, but metoprost lowered IOP 7.5 millimeters of mercury. And so 1 millimeter of mercury, does this matter? Well, remember back to the collaborative initial glaucoma treatment study, or the CIGITS study. This is one of our landmark studies in glaucoma. And that study said that every 1 millimeter of mercury IOP lowering equals 10 to 13% reduced risk of glaucoma progression. And so, yes, I think that matters. Let's review a newer glaucoma medication to the market, latanoprost emulsion 0.005%, or Xelpros. Xelpros is a BAK-free. It does not have an ammonium surfactant or BAK type preservative. It is still a latanoprost emulsion. It comes in a sterile 2-way valve bottle. And so it's a multi-use preservative-free bottle. And the key here is the swollen mycelial microemulsion, or SMM technology. This is a micro technology, and it's the way that they're packaging the latanoprost molecule. The vehicle that's encapsulating this tries to be micro in size, smaller, to get better penetration, to be able to get through the tight junctions of the cornea and the epithelium. And so we're trying to get this technology to get us better penetration into the aqueous with the latanoprost molecule. Reduces IOP on average 6 to 8 millimeters of mercury, so on par with other topical PGAs. And this is a different route of medication for our patients. It's a topical drop, but it doesn't go through their local pharmacy. You don't order this to Walgreens or CVS. It's a manufacturing shipping pharmacy, and it's actually a cash pay model for patients. It's not working through an insurance pathway. And so here's 1 year later. And so in total, we're about 2 years from our first visit with this patient, but we're 1 year from that 15-month visit. Patient's on prostaglandin analog once a day, still has great vision. IOP is 18. So we lowered it from a Tmax of 27 down to 18. Pachymetry, you can see optic nerve head evaluation. We have a little bit more cupping in both the right eye and the left eye. Here's the OCT of the retinal nerve fiber layer. We have a little bit of progression to the inferior temporal retinal nerve fiber layer thinning. That matches very closely with now a reliable superior nasal step or superior nasal partial arc. We have inferior temporal thinning, superior nasal visual field loss, and we have a patient that's progressing. This is the left eye, the visual field, and OCT on the right eye had a similar presentation. And so for this very same patient on a prostaglandin analog who's progressing, I would now suggest switching to a prostaglandin plus nitric oxide donor, being Vyzulta, add a beta blocker in the morning, add a combination med like dorzolamide timolol twice a day, or I'm going to send this patient or do SLT in my office. Pretty equal split here. And so 20% said switch to Vyzulta, 35% most common answer, add a beta blocker in the morning. Least common answer, add a combination med, or finally recommend SLT for this patient. And so we decided to switch medications from generic latanoprost to a prostaglandin plus is what I call this. This is latanoprostine bunad 0.024%, or Vyzulta. Vyzulta combines 2 mechanisms of action to lower the IOP. We have the latanoprostine molecule, so increasing uveoscleral outflow, but Vyzulta also has a nitric oxide donor, which aims to relax and expand the trabecular meshwork. Exogenous nitric oxide goes in and relaxes the trabecular meshwork cytoskeleton. Hopefully we have less rigidity, larger pores for aqueous outflow through the TM with this medication. On the right, this is the Voyager study. This was one of the pivotal studies for Vyzulta. They looked at latanoprostine bunad at various concentrations versus latanoprost once a day. And what they found is there was a statistically significant improvement in IOP lowering, 1.5 to 2 millimeters of mercury with LBN 0.024% in comparison to latanoprost. What we're looking at on the bar graph is actually adverse events for patients. And my experience is patients tolerate this medication very well. It tends to be a very low callback medication in our practice. Patients don't have a lot of big side effects from it. This is taken from the study. Number one side effect or adverse event was site installation pain, and so stinging and burning after putting in the medication. Latanoprost actually fared quite well in this study for adverse events. Ocular hyperemia was the most common at under 10%. Zooming in on nitric oxide a little bit here, this is something we have in our body. It's endogenous to us. It causes our cytoskeleton and different tissues to be either relaxed, or if we have a lack thereof, it kind of causes compression or rigidity. And in glaucomatous patients, we have reduced nitric oxide in the trabecular meshwork, Schlemm's canal, and the ciliary muscle. And so if we can add nitric oxide, hopefully we can get these tissues to relax, increase aqueous outflow through the conventional pathway. This is a retrospective chart review on latanoprost Gunod 0.024%. This is a single site clinical trial. These were patients who were all naive to treatment before starting Vyzulta once a day, all had open angle glaucoma. They looked at IOP lowering as a whole, as well as broke patients up into two buckets: baseline untreated IOP greater than 21 and less than 21. Here's the highlights from the study. The mean IOP lowering in both groups, so irregardless of starting IOP, was 7 millimeters of mercury. When they split the cohorts up, for patients who had an eye pressure at baseline greater than 21, they actually got 10 to 11 millimeters of mercury of IOP lowering, or a 41% reduction from unmedicated baseline IOP. Impressive IOP lowering for patients who have high IOPs at the start. For patients who had a baseline IOP less than 21, they got less than 5 millimeters of mercury, or about 22% reduction in IOP from baseline. And so, like almost all medications, like laser treatment in glaucoma, like many of our MIGS procedures, where you start with IOP matters. It's much easier to get an eye pressure in the high 20s to come down into the mid-teens than it is to get a pressure in the mid-teens to come into the pre-teens. And so where you start matters. That's also what was found in this study here. And so let's transition to a new patient here. This is patient DB. This is a patient who presents for a glaucoma evaluation, referred from their primary optometrist. This optometrist gave me a call and said, I think this is a patient who's worsening. I'd like you to take a look because I'm nervous that we're progressing and we're not doing enough from a treatment standpoint. And so this is actually a chart note from my practice. This is kind of how I try to walk through in my mind a new glaucoma eval coming into our practice. I have their chart before I go into the room. And so the first thing I'm going to look at is age. Age matters to me in glaucoma. Remember back to the OATS study, we said increasing age is a risk factor if you have a patient who has high eye pressure and their risk of going to glaucoma. Second, I'm going to treat and take care of a 67-year-old with glaucoma much differently than I am an 87-year-old with glaucoma. We probably have to take more risk in that younger patient in treatment or be more aggressive because we have more years to try to have non-progressive glaucoma. After introducing myself, we'll walk through the chief complaint, and then I'm always trying to ask 3 questions on a new glaucoma patient. First, if they've ever taken medications before, if they've had side effects or adverse reactions to medications, what's their past history with meds? This patient's taking latanoprost. Their Tmax or max IOP. This is helpful because I know that currently if this patient's at a pressure of 19, but they were at 39 Tmax, we're maybe doing okay on just one medication. Then finally, family history. I think there's enough data now to support that there is a familial component to glaucoma. I mostly care about first-degree family members, so mom, dad, brother, sisters, son or daughter. I'm less worried about great aunt Helen, who may be partially removed or married into the family. I really care about that kind of core 6. As we continue to move through, next is the patient's refraction. You're probably thinking, well, I'm not worried about a refraction in a glaucoma patient, but I am, and for a few reasons. First, we know that myopic patients have a much higher risk of pigment dispersion glaucoma. Hyperopic patients, much higher risk of angle closure glaucoma. What's the brightness acuity testing? Is this patient who has a clear lens and I'm trying to bridge treatments, maybe until phaco plus a surgical treatment? Is it a patient with a visually significant cataract, where in our practice, we're almost always going to couple with a minimally invasive glaucoma surgery? If they have glaucoma and cataracts, we like to treat both when we can. Or is it a patient who has a pseudophakic, has an intraocular lens, and now we're maybe adding back treatments. And then finally, afferent pupillary defect. Remember, APDs are based on visual field loss, not visual acuity loss. Continuing with our clinical exam, keying in on things like a Kirkenberg spindle or radial transillumination defects for some of our secondary glaucomas. Is this a patient with pseudoexfoliation? IOP, of course, this matters. This is the modifiable risk factor. This is what we're treating in glaucoma. Pachymetry, we know that pachymetry matters. It heavily influences the IOP measurement, although there's some new devices, ocular response analyzer, CATS tonometer are two that are trying to differentiate or be able to separate out corneal thickness from our IOP measurements. Corneal hysteresis, we've talked about. Gonioscopy, becoming comfortable and confident with gonioscopy if you're managing a lot of glaucoma is something I think that's really important. There's a study out of Canada where a tertiary referral center for glaucoma patients are being referred in for glaucoma. Over 10% of patients referred in for primary open angle glaucoma were actually an angle closure or an angle closure glaucoma patient. And so doing gonioscopy, I think, is really helpful, especially for classifying the disease. And then finally, the optic nerve head evaluation. Become comfortable with a 90 or 78 or whatever type of lens that you use to look at the optic nerve. For this patient, we had a near notch at 4 o'clock. We just confirmed with the OAT study that visual field, specifically pattern standard deviation, matters in glaucoma. So let's look at the visual field here. Right eye on your right as your patient sees it. Anytime I'm analyzing a visual field, the first place I'm going to start is in the top left, looking at the reliability indices. Is this a test that we can gain value from, or is this just garbage in, garbage out? In both eyes, we have reliable tests here. Second, I'm going to go to the total deviation and pattern standard deviation probability plots. That's shown more on the bottom. Remember, total deviation often will look a little bit worse because it doesn't take out the distractors of media lens opacities or pupil size. And so I'm kind of a pattern standard deviation probability plot guy myself. And looking at this patient, right eye, we had some scatter. Left eye, we definitely have a superior paracentral arcuate defect. This is probably a moderate visual field defect, even though I have mild written here. Remember that this patient had a near notch at 4 o'clock in this eye. And so this adds up, structure matches function here. Continuing with the visual field, on the right, we have the visual field index. This is proprietary to Zeiss and the Humphrey Field Analyzer. This is a percentage score. 100 would be a perfect visual field, no loss. 0 would be total blackness. This is heavily based on mean deviation. The mean deviation, this is looking at how far is our patient depressed below the normative database for that patient's age and gender. It's going to be a negative number. The higher the negative number, the more advanced the visual field loss. And then pattern standard deviation, again, takes out those distractors. It's a positive number. The higher the positive number, the more advanced the visual field loss. And looking at OCT, this is what we have, right eye shown on your left. This patient, remember, in the right eye, we had maybe some scattered defects, but this patient likely has some temporal retinal nerve fiber layer thinning. If we zoom in on just that macular ganglion cell area on the top right, just some generalized thinning there. Left eye, we have thinning inferior temporal, which matches back to our visual field, which matches back to the near notch at 4 o'clock. And so pretty significant inferior temporal and central retinal nerve fiber layer loss in this patient's left eye. And so this patient's referred into our practice. You're now the doctor getting this referral in. This patient's on a generic PGA once a day. The eye pressure is 14. How are you going to treat this patient? Switch in class to a name brand PGA like Lumigan once a day. Add a rho kinase inhibitor, Ropressa, once a day to the left eye. Add a combo med, dorzolamide timolol, twice a day to the left eye. Recommend SLT or refer for glaucoma surgery being a tube shunt. Most common answer on the board was sending for SLT. I think that's a fine option. Interestingly, this patient's baseline IOP, we don't know, but it's 14 on one medication. I very commonly think of SLT being pretty equivalent to one prostaglandin analog, but I think it's a fine option to try. Second most common answer is adding a ROCK inhibitor once a day. That's actually what we did, and I'll share why. 16% said switch in class. I think you might get another 1 millimeter of mercury here. Is that enough? Add a combo medication like dorzolamide timolol twice a day, a popular answer as well. I'm happy to see that only 4% said they're referring for a tube with this level of glaucoma loss. I think that's maybe being over aggressive or taking more risk than we need to. And so we showed that Susanna et al. Study earlier, which looked at the risk of glaucoma suspects moving to glaucoma. But what about a patient with glaucoma? What's their risk of progressing? This is a study by Condon et al. This is 230 patients with primary open-angle glaucoma. They used a minimum of 5 years of visual field follow-up. And then they tried to correlate back what other diagnostic tests or measurements equate most strongly or associate most strongly with visual field loss. And here's what they found. Treatment of IOP, lowering IOP, and baseline corneal hysteresis measured in millimeters of mercury most strongly correlated with visual field loss. Remember, a low p-value is better. And so baseline corneal hysteresis can not only help tell me which patient's at risk of going from glaucoma suspect to glaucoma, that baseline corneal hysteresis can also tell me maybe who is going to be a fast progressor versus a slow progressor. And so for this patient, I said we added a medication once a day. It was notarcetyl 0.02% or Ropressa. I also think adding a combination med twice a day in this left eye makes a lot of sense. And so we'll cover kind of those two options. Notarcetyl is a ROCK inhibitor or Rho kinase inhibitor. The primary mechanism of action tries to relax the trabecular meshwork, have a less rigid TM so that we can get conventional outflow or increase fluid to flow through the trabecular meshwork by relaxing that trabecular meshwork cytoskeleton. Ropressa also has a secondary mechanism of action of trying to lower episcleral venous pressure. I think of EVP as the floor of IOP. And so some of these tough patients where we already have low IOP, trying to lower episcleral venous pressure, I think is a nice theory or a nice idea for these patients. We're really targeting, though, conventional outflow here first, which is the primary disease tissue in glaucoma. Here's data from the MOST study, the multi-center open label study. I think this is a really powerful study for additive treatment with drops in our glaucoma patients. 161 patients who were taking either a prostaglandin analog once a day or 2 or more medications. They weren't reaching the IOP target, and they had notarcetyl added once a day. And the conclusion is, regardless if a patient was taking a prostaglandin and then they added notarcetyl, or 2 or more medications and they added notarcetyl, at week 12, the IOP lowered 4 to 4.5 millimeters of mercury, or an additional 20% reduction in IOP. So irregardless where you started, how many medications you were on in the MOST study, patients got an additional 20% reduction in IOP. Here's the adverse event data from the MOST study. Some important precursors here. This was not an FDA clinical trial where there was masked examiners and standardized scoring. And so the adverse event profile is a little bit less in this study than you would see if you read the pivotal trials for notarcetyl, but conjunctival hyperemia at 20%, blurred vision at 7%, and then conjunctival hemorrhage and sight installation pain at about 5%. For notarcetyl or ROCK inhibitors as a category right now, 3 big adverse events to know: conjunctival hyperemia, whorl keratopathy, or similar to your amiodarone patients, this kind of whorl-like pigment on the anterior cornea, and then petechial conjunctival hemorrhages. That's the big 3 to know. Another option for this patient, though, if you decided to add a combination med twice a day, I think that's another really good option. But which combo med do you add? I think this study perfectly reflects our scenario for this patient where we're on a PGA once a day, we're progressing, and so we're going to add a combination medication. 80 patients here. Patients were randomized 50-50 or into 2 buckets. Half of patients got dorzolamide timolol twice a day. Half of patients got brimonidine timolol twice a day. In both groups, the medicated IOP was in between 21 and 22 millimeters of mercury. And at 3 months, dorzolamide timolol lowered IOP 5.2 millimeters of mercury, or got an additional 23%. Brimonidine timolol lowered IOP 6.9 millimeters of mercury, or almost 30%. The side effects and the discontinuation rate were nearly equal in this study. And so brimonidine timolol outperformed dorzolamide timolol in this study here. Let's go to our last patient, patient MW. This is a low tension glaucoma patient, 75-year-old female, and she's concerned that visual acuity is worsening in her right eye. Current IOP of 13 and 9. 6 months ago, it was 14 and 13. Tmax is 15 and 17. Currently taking 3 topical glaucoma agents, dorsal timolol twice a day, Lumigan once a day. You can see the pachymetry, low corneal hysteresis, open gonioscopy, cup to disc ratio of 0.8 on the right, and we can see that Drance hemorrhage there at 10 o'clock. And so here's what we see for the OCT progression over time. On the far right, if we're looking at event-based analysis, we see progression, pretty slow progression to the inferior temporal retinal nerve fiber layer quadrant, but we have faster progression superior temporal. On the bottom left, this is the Hood report. This is from Heidelberg's OCT printout, but the Hood report is putting more emphasis on temporal retinal nerve fiber layer or ganglion cells. We're trying to catch this ganglion cell loss earlier, which correlates with central visual field loss. On this Hood report here, we see a very damaged superior temporal and inferior temporal ganglion cell picture, which is going to most commonly correlate with a paracentral defect on 10-2. Here's the right eye visual field over time. You can see over the past 2 years, we have progression from a pattern standard deviation of 4.96 to 6.82. It's about 1 decibel of progression per year. If you look at the pattern deviation probability plot, we're losing more central visual field here. This is definitely affecting this patient's papillomacular bundle. And remember that patients care about visual field loss. This is what is quality of life affecting in glaucoma to them. And so this is a low tension glaucoma patient. What is your treatment goal in low tension glaucoma? It's irrelevant to lower IOP and LTG, a 25%, a 30%, or a 40% reduction. Most common answer, 30%. Second most common, 25%. I think both of those are right. Let's look at the collaborative normal tension glaucoma study to help us answer that question. This is one of our landmark glaucoma studies, 140 patients with low tension glaucoma. And this is pretty advanced disease in CNTGS. All patients were either progressing in low tension glaucoma that were enrolled in the study or had central visual field loss. They followed patients for 5 to 7 years. Patients were randomized into the treatment group, where the goal was to lower IOP by 30% from baseline, or they were randomized into the control group where they were untreated. They had no therapy. And at 5 to 7 years, over half of the non-treated low tension glaucoma patients did not progress. Of the patients who were treated, less than half got to the 30% reduction in IOP, and some treated patients still progressed. In the treatment group, on average, 6 millimeters of mercury reduction in IOP, and the take-home is shown in orange on your top right. For glaucoma progression on visual field, in the treated group, patients progressed at 12% clip compared to the untreated group at 35%. And so the take-home is treating low-tension glaucoma in this study slowed visual field progression 3 times. And so back to our patient, she's on 3 meds. She's on a PGA, a combo med. And so we changed her prostaglandin analog to notarsidil plus latanoprost, which is on label as rocklatan. Rocklatan has 3 mechanisms of action. Now we have notarsidil, or the ROCK inhibitor, to try to increase trabecular meshwork outflow by blocking actin and myosin stress fibers. We have the ROCK inhibitor to lower episcleral venous pressure, or the floor of IOP. And then we have latanoprost to increase uveoscleral outflow. Rocklatan went through the Mercury trials, Mercury 1 and Mercury 2. In these studies, patients were high eye pressure glaucoma patients. Rocklatan was superior to its 2 individual counterparts, IOP lowering of 8.5 millimeters of mercury, but that's high eye pressure glaucoma. Our patient has low eye pressure glaucoma. And so let's look at normal tension glaucoma patients, first by defining episcleral venous pressure. This is the back pressure against conventional outflow. It's in the episcleral veins, most commonly blood. 8 to 11 millimeters of mercury is normal, and notarsidil has been shown to lower episcleral venous pressure. Arthur Sitt, again at Mayo in Rochester, Minnesota, showed this with having patients take notarsidil once a day versus placebo once a day for 7 days, and notarsidil lowered EVP by 10%. Why does that matter? We'll go back to the Goldman equation where IOP equals aqueous production divided by aqueous outflow plus EVP. These are 1-to-1 ratios. And so lowering EVP by 10% will lower IOP by 10%. And so in the last 53 minutes, we covered a whole lot of material, but I'll oversimplify glaucoma management for the medically minded OD in 4 things. Number 1, diagnose glaucoma early. Get into the game early. Unfortunately, visual field loss and optic nerve damage is irreversible. Number 2, lowering IOP is still our mainstay in treatment. Number 3, monitor closely for progression. Do more than just IOP. Let the visual field and OCT dictate. And when you feel uncomfortable, refer these patients out. And then remember, our ultimate goal is to save vision and visual field. With that, I want to say thank you guys. Thanks for coming out tonight, spending an hour with me. Thanks to Stephanie and Wu University. I did put my email here at the bottom. I look forward to emailing back and forth and answering some questions from you guys.